Hello guys, and welcome to this video to learn about ankylosis, alright? So first of all, what is ankylosis? And basically it is the fusion between the tooth and the underlying bone, right? And that actually happens because there is a necrosis of the periodontal ligament, so the tissues of the periodontal ligament, and then what you have is a fusion between the bone of the socket and the cementum of the tooth, alright? That's actually a fusion between two mineralized tissues, and that's why the tooth becomes basically bounded and completely attached to the bone. And as you guys can see, this of course will be something that will make the extraction a little bit more difficult, right? So how to proceed with an extraction of a tooth with ankylosis? And first of all, we need to understand how to diagnose the ankylosis, all right? So let's start by the image on the top left corner of your screen, okay? There is a recommended reference here on top of myself as well. Let's understand what's going on here. So, of course, we are talking about the retained root of this canine, all right? And it might seem that we have the proximity between the canine and the lateral, but not really. This is basically the superimposition. Don't forget that there is a curve of the dental arch and a curve of the ridge, okay? Basically, the correct radiograph here would be a radiograph of canine and lateral incisors. So the canine and lateral incisors should be completely parallel to the radiograph, and that's actually not really what's happening here, right? This interproximal space between the lateral and the central incisor is actually better depicted than this interproximal space, okay? So basically the film should be a little bit more to the distal, okay? And then the X-ray source as well, completely parallel to the interproximal spaces, all right? So that's basically what should happen here, and it's not the best radiograph as a result, okay? Now we have here what we need to diagnose before an extraction on the radiographs. And one of the most important things is the periodontal ligament space. So we have here the periodontal ligament space. We do have a nice periodontal ligament space here in continuation with the distal alveolar crest. So here you have some space, and that's the space you want to open and to widen with your elevator for the extraction. Here you have space, but now try to follow this space upwards. So now we have the periodontal ligament space, and then what's going on here, you don't see it. Okay, so you don't even see what is lamina dura, what is periodontal ligament space. I will give you a zoom for you guys to see better, okay? And take a look at this, right? So this area, for example, you don't know what is going on here. Okay, of course, there is some radiolucent images, small images, which is basically the same of the underlying bone. So basically, you can still see the underlying bone superimposed to the tooth, so behind the tooth, right? That's why it's not completely radiopaque, the tooth. But that's not really the periodontal ligament space, okay? The periodontal ligament space is basically here. Let me see if I can draw this line here. So we have here, let me use this line. So there you have it. You have the periodontal ligament space, and then from here we are not seeing anymore. Okay, so we are not seeing anymore, and then you see again only here. Okay, take a look at this. So now we see again the periodontal ligament space, you see? And this area in the middle is, of course, just an area that we might have ankylosis because, of course, from the radiographic point of view, because we cannot see the periodontal ligament space properly. Let me remove the zoom so that you guys can see the correct tooth location again. And then let's just finish diagnosing this radiograph as usual. We have more alterations here. I hope you guys realized all of them. If not, pause the video and try by yourselves first. And of course we have this post, and the post should be following the root canal, but now of course there is a deviation, right? And now there's a deviation, and only we don't have a lot of dentin thickness here, right? And that's actually something very bad for the prognosis of this tooth. Okay, so that's something very bad. Then we have the root canal treated to the apex, but now we have also this image here, which could be, just some root canal materials that went through a lateral root canal of this root. But okay, so we can still see the periodontal ligament space, and that's fine. We have a crown here with some overhangs, and then we have the overhangs of this crown here, and of course the fracture, okay, so or a crack, okay. That's an image suggestive of crack or fracture of the crown because there is an interruption of the continuation of this structure, right? So that's how we see this, the mesial overhang, and then as a result we have horizontal bone loss. Okay, so we have horizontal bone loss. There's a huge bone loss here, of course, horizontal bone loss because of the dentulous area. Even some vertical bone loss here, mesial vertical bone loss, and then of course, all this as a result of periodontal alterations, right? The maxillary sinus is very close to the root of the canine, so that's something you want to diagnose before an extraction. But all right, so it seems that we have the contact or the continuation between the root of this canine and the lateral, the mesial wall of the sinus. Okay, so it doesn't seem that this root could be displaced into the maxillary sinus. Right, so that's how we would diagnose this case. If you don't remember, go back, rewind the video a little bit to make sure you have the case diagnosed, okay, at least from the point of view of this radiograph, of course. And then what we need to do now, so let's go for this picture here, and as usual, we need to use our luxators first, and then the elevators on the space that we opened with the luxators. Index finger, okay, so if you don't remember how to hold the instruments, forceps and elevator, I will add the link of basic knowledge of extraction regarding these instruments on the top right corner of this screen. It will show up at some point in this video. And then, so of course, first time we are taking advantage of the distal periodontal ligament space, okay, and there you have it. Okay, you can see we have this periodontal ligament space, the distal, and then the mesial periodontal ligament space completely detached from the other tooth. Okay, so they are actually two different spaces, okay? You should always act in the level of the root, not in the level of the crown, to avoid damaging the adjacent crown, of course. But if you are in the level of the root of the periodontal ligament space, then absolutely fine. And then you would listen to, so you would do rotation after you engage with the instrument, rotation, pressing in still, then rotation, and then even some lever action, and then you would listen to some crack, 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 okay, because you are actually detaching the ankylosis area from the socket, right? So you are detaching the tooth from the sockets, and then eventually you would also take advantage of the mesial periodontal ligament space, all right? And then take a look at this. Here, you might think that this elevator is not completely parallel. Let me go with this too. So it's not completely parallel to the interproximal, to the mesial surface of this root, but it was parallel, and now we are also using some lever action because the root is already coming out. That's why, right? So you can see that the root is now coming out. Okay, so it's completely luxated. You are rotating, and then you are also giving some lever action to this, and then then it becomes just a normal extraction, right? And there you have it. So you have the ankylosis, so the cortical bone, which was fused, and it is still fused to the cementum of this tooth. And of course, the location is not completely accurate as assessed from the periapical radiograph, because that's 2D, of course, that's 3D, right? So maybe we are seeing a little bit more like this area here, for example, but it's basically 2D, right? If you had a CBCT, then of course you would be able to assess this in 3D with slightly more details, okay? So again, take-home message, we should diagnose first from the radiographs, if possible. If you have a CBCT, even better, but depends on the indication for every single case. And then after the diagnosis, then you should take advantage of the periodontal ligament spaces that you are diagnosing at the cervical third of the root, of course, because that's the first one that you are going to open with your luxator, to make sure that you have a correct strategy for extracting this tooth. All right? Don't forget to review the recommended reference. Okay, send questions because we are always addressing your questions in the shorts video of this YouTube channel. And see you guys on the next video.